Welcome to Nursing Grand Rounds. There are no disclosures of financial intent in this presentation.
All right, hi, my name is Evie, and I've been a nurse here for 21 years, and I'm currently in the quality department. I'm one of the clinical quality analysts who abstracts and enters data for Get With The Guidelines resuscitation. Next slide, please. So Get With The Guidelines is a program designed by the American Heart Association, and it's used to collect data and evaluate how we are adhering to the guidelines, resuscitation guidelines with ACLS. Get With The Guidelines measures have been shown to increase rates of ROSC and survival outcomes. And the goal by using this program is to provide quality-driven, evidence-based resuscitation for all of our patients here at ANMC. We started this program in November of 2016. And there are 4 recognition measures that we track with criteria, but many more details are actually abstracted from the documentation. Next slide. So a cardiopulmonary arrest, everyone knows what that is. However, for an event to qualify for Get With The Guidelines, chest compressions need to be done and/or defibrillation of ventricular fibrillation or pulseless VT. So if a code was called and you actually didn't do chest compressions, and they weren't defibrillated or they weren't in pulseless VT, then we do not add that case to Get With The Guidelines. And the Resuscitation Committee has revised the code blue, code white flow sheet so we can capture the data that we're tracking for Get With The Guidelines. And I'm going to go through some of that information and documentation. So the documentation, the code blue, code white flow sheet is the main source of data abstraction for analysis. And really when you have a code, think of the code blue flow sheet as a timeline of the interventions that have happened during the code. We review, the Resuscitation Committee reviews all of the information. We review the code sheet, we review the rhythms, we review all of the documentation, nursing narratives very closely when we review our codes on a monthly basis. So this presentation is here to discuss the documentation to capture the data that I enter with Get With The Guidelines. Next slide. I just want to add a few things to think about when you are on the ward and considering what to do during a code. Think ahead about how you or your coworkers might respond. 5 East, I believe they're still doing that. You can correct me if I'm wrong, but I believe they're assigning roles. They're going to have shifts. Who's going to be a documenter? Who's going to be give medication? Who's going to do vital signs? Because there's been some confusion during codes. So think about how you might respond during a code. And don't forget the documenter. The nursing supervisor here at ANMC is generally the person who documents, but they may be busy and they may not arrive at a code for 5, 6, 10 minutes. And if we don't have information documented, then I can't extract that data. It's important to call out pertinent information, such as your vital signs, end tidal CO2, heart rhythm, confirmation of airway as it's happening, so that the documenter can make sure they capture that information. Again, this information is all the data that I need to enter into Get With The Guidelines. And of course, don't forget closed loop communication. Good code tips. Next slide, please. So these are the 4 adult measures. I'm only going to go through the adult measures because we have very few, but a knock on wood, pediatric and neonate codes. So these are the measures for anyone over the age of 18 years. The first measure is time to first shock is less than or equal to 2 minutes for VF or pulseless VT as the first documented rhythm. So when you get the patient on the monitor, you need to check what rhythm that patient's in, because you got to defibrillate them quick. Defibrillation is key to survival, early defibrillation. The second measure is time to IV IO epi, less than or equal to 5 minutes, for asystole or PEA as the presenting rhythm. And percent of pulses, cardiac events monitored or witnessed is the third measure. And then confirmation of airway placement in the trachea is the fourth recognition measure for Gatwick guidelines. And then I'll kind of touch base on these again. Next slide. So this is our code blue flow sheet. And like I said, we have this created for the data abstraction. I had a pointer. The first box you're going to see is the time the event was recognized. So that's when the clock starts ticking. If you call that code at 11:40, we need to have that patient defibrillated between 11:42. That's within 2 minutes. So that's where we get some of these times. We also abstract times from rhythm strips and whatnot, but really this code sheet is the #1 place where I abstract data from. Was the event witnessed? Was there a nursing assistant there? Was the nurse at the bedside? Was a hospital-wide response activated? That's another question that we ask. Reason for compressions for defibrillation. Were they pulseless? Did they have a pulse? There's a section in there on the next slide with this next question. Did the patient with a pulse requiring compression become pulseless? Yes or no? So this actually pertains to patients who are bradycardic and you were giving compressions before they came pulseless. So there's a little bit of confusion with that question.
And it really pertains more to pediatric patients as well, in a big sense.
And so Julie, one of our members of the resuscitation committee, who's a great ACLS instructor, says this question mainly pertains to pediatric patients.
Because if they have a pulse of less than 60, we ventilate, and if the pulse doesn't come up, then we're going to add compressions.
And if you go, well, go next slide there, Shelley. See where we're at here. Actually, why don't we go back to, sorry.
Yeah.
So that's the first box. And then we go to airway ventilation. How is the patient breathing and a time to a first assisted ventilation? This is another abstraction question. Were you bagging them? Did they have an ET tube, a trach? And was there an existing airway device present? So that means if you're in the ICU and they're already intubated, do they have an existing airway device? Yes, you would circle yes. And just because they have an existing endotracheal tube doesn't mean that the device is in the correct position. So confirmation of the airway is extremely important, and it is one of the measures, recognition measures, that we're looking at. So it has to be confirmed at the start of the code. And we want to know the time. Whom is good, but the time is that abstraction, and how it was confirmed. And we will review some exhaled CO2, how to get that connected in a few minutes here. If they were intubated, please note the time they were intubated, and again, how was that device confirmed. So it's important to call that information out if you're doing that, if you're an RT, if you're a nurse and you're at the head of the bed, and you know, it was just done, and maybe the documenter didn't hear you. It's important to capture that information. When the documentation gets done, the chart oftentimes is after the fact, so it's hard to get that data. It's really important. I left copies of this sheet so you can look a little closely at it. As we progress through, I have some blocks that are pulled out for the slides. If you could advance the slides, please, Shelley. Okay, so we just talked about time to first assisted ventilation. I'm going to repeat this again, because this is a measure where we seem to be, our numbers could be better. How are we ventilating them? Do they have an existing airway? Yes or no? And how was that existing airway confirmed? And was the intubation confirmed as well? Fill in the blanks. The blanks are there so you can fill in all the blanks. So just go through and answer those blanks. Next slide, please. Again, confirmation of air device placement in the trachea is key to managing the patient's airway effectively. Misplaced airway can delay ROSC and contributes to morbidity and mortality. And this is again just showing the importance of this question. Is there an existing airway device? Yes, confirm it. Please confirm that existing airway device. That's how important this is. So I've got numerous slides on this. You can go to the next slide, Tony. All right, and as I mentioned, the clock starts ticking at the time the event was recognized. So we have 2 minutes to defibrillate to meet that measure. For IV, IO, Epi, we have 5 minutes or less. So we do excellent on the Epi. We're always, almost always, since I've been in this role, 100%. Lately, we have not been meeting our measure for time before shock. So I think we just need to remind everybody when you get those pads on, check what rhythm the patient's in and they need early defibrillation. Do you have anything to add on that, Julie, as an ACLS instructor?
I think the difficulty is getting the crash cart to the patient and getting them on the patient. So that's where reality comes in.
That's a good point.
More than people, and because it's practiced in ACLS and PALS and such as well. So I think reality skews that number.
And I think you mentioned, talking to you before at the beginning, try to get the crash cart
Oh, yes.
closer to the head of the bed. Go ahead.
Yes, you're absolutely right. The crash cart really should be across from the person who's doing compressions for 2 reasons. They need to see the CPR dashboard and also for the end-tidal CO2 to reach the ET tube.
I'll show you how long that is. So this is how long of a cord it is from the Zoll monitor to the ET tube. So we don't have a whole lot of length there.
And the interesting thing is that, can you grab that and show them how long that is? So should always be hooked up to the pad. So this can reach further than this to the ET tube really. So this often the crash cart can wind up at the foot of the bed and it get attached easily, the pads to the patient. But then this gets neglected. And what happens is we don't get that feedback for the compressor if it's at the foot of the bed. Because boy, you would have wicked whiplash having your head turned doing compressions, looking back at the foot of the bed.
Remember, these Zoll devices have the, what do we got, the assisted
CPR dashboard.
CPR
that
dashboard.
shows rate, depth, and idle time, how much time we're off the chest.
So when you're doing compressions, try to be in view of the monitor so you know how your rate and depth of compressions is.
Because that
How well you're
instant
doing.
feedback is amazingly effective in delivering quality compressions.
We are starting to capture this information as well, and so the resuscitation committee, we're going to start looking at each case that we're able to upload the information from the Zoll unit. So we're getting some really valuable data on our quality of CPR and how we can direct education. Okay, let's see, where were we here? This is kind of a middle box on the code documentation sheet. The first rhythm requiring compression, so that's if you write VFib, VTAC there, then I'm going to look for defibrillation within 2 minutes. If it's PEA, I'm going to look for epinephrine given within 5 minutes. And then the time the chest compressions were started, that's a key data abstraction question, and were the Zoll pads applied and what time. Next slide, please.
Can we go back to that one? The back one slide. So the first two lines can be the exact same rhythm. It doesn't have to be two different rhythms. Because if you present in VFib, it's also the first pulseless rhythm. Because it's kind of confusing the way it's written a little bit.
Very good. Thank you. All right, one of the next get with the guideline measures is percent pulseless cardiac events that were monitored or witnessed. And this is important for several different reasons. You know, a patient who codes hopefully will be in a monitored bed, but that's not always the case. Was there something going on? Was the nurse at the bedside because she was concerned about the patient that they went into arrest? Or was this a patient that we had no expectation that any kind of event was going to happen, and it just happened? Unwitnessed events have a delay in resuscitation efforts and thus poorer outcomes. And what we really find helpful are the nursing narratives. The resuscitation committee loves it when the nurse writes exactly kind of what happened. You know, the nursing assistant walked into the room, noticed the patient was breathing kind of funny, so the nurse was called. All that information really helps to paint a really accurate picture for us as we review the information. And remember, this information that we review is for quality improvement, it's for letting people know what went well, and it's really just, you know, where we're at and the direction we need to go to for more education. Next slide, please. This is the bottom of the flow sheet where it starts. There's only a few lines here on the bottom of that first page, but it is continued on the second page. So we have the time over to the right, and end title monitoring has its own column, and also the heart rhythm. A lot of times we forget to document that as the code goes, and remember your end title monitoring gives us a good information on the quality of CPR that's being delivered. And after this, Brian will talk about some of those numbers when we get to end title.
And we minimally want those boxes filled out every 5 minutes.
Every 5 minutes, yes.
It can be more often.
Whenever if you are putting a time down and you have the end title, write it in. That's great information. All the meds are listed there, so you don't actually, you know, sometimes I see people write epi. You don't have to write epi, you can just do the dose, IV. And under the comment section, the peripheral IVs started, IOs. Please document that you flushed the IV and that it's patent and working. That's helpful. And any other response to interventions, if anyone else showed up, anything you want to document. There's not a whole lot of space, but just do your best in filling that in. Next slide, please. Again, we're mentioning end title a lot because it's a standard of care, and we've been a little bit shy on doing that in this facility. It is an ACLS standard, and it evaluates the effectiveness of CPR. And we have these new ZOLs that allow us to monitor for end title. Please note all rhythm changes on the flow sheet. And if you're writing a time down and you know what the rhythm is, please write it in. Another big thing is time. When you are recording the time, try to use one source, please. The ZOL monitor should have a time on it. If you have your iPhone or the wall clock, just use one, just to make sure you're consistent with your time, because time is really key when I'm entering this information. Next slide. Again, this is the back of the form. You've got a lot more boxes to fill in. And at the bottom, there's the signature area. Don't forget the signatures of your recorder, pharmacist, team leader, medication nurse. And also, on the front of the top, it has the names. Print those names, because if we can't read who was at the code, if we need to contact someone or ask me questions, we may not know who that is. Also, if you can print, if you're documenting and you know his folks, ask the last names, print those out for us so we can understand who's there. Next slide, please.
And sometimes the code can go on for several sheets. You just need to use that second sheet
Yes.
over and over and over again. You don't have to start with the first sheet of the two sheets.
Just grab another sheet and you can just write on the back side. And if you need another sheet, grab the next one, write it on the back side. You don't have to have that first sheet for each one. So, I know documenting during a code is very, very hard. It's hard enough when we do ACLS and the practice sessions we had during a code. There's even more stress. But challenge yourself. Take a few minutes after the event to add in anything. It's okay to transcribe the information onto a new code flow sheet. We just need the data to be legible, to be visible, so we understand what's going on. And familiarize yourself with the documentation sheet. I gave you all copies. You can find the form on the documentation library on the internet. And the new form should always be on the clipboards. Those clipboards, however, do get sent down to CSS, and sometimes they come up with the old sheets on it. If you are that person checking off your code sheet for the shift or your crash cart for the shift, take a look at that code sheet, make sure those are the new ones on there. And the way you can tell is a date at the bottom, and it also says, is there an existing airway device? Because we added that. Next slide, please. This is the post-code evaluation form that we revised from the 3 or 4 page overhead. And on the crash carts, you'll find it copied in blue, for code blue. This form provides valuable information about the quality of the code. It communicates information that we are not aware of. If there was equipment missing, biomed work orders, medications, were they available? How was the code run? Communication with the team, all that good stuff. So please try to complete it thoroughly. This is the front of it. Family present. We also discussed that during the resuscitation. We always ask if the family was present. That's another issue. Next page, please. This is the back. Any other comments you want to make? Was there a debriefing? You can request a formal debrief if you'd like, if it was a really long, hairy, drawn-out code, and you feel like the team needs to talk about it more. There's a checklist at the bottom. Tells you exactly what to do with all of the documents. We need the code flow sheet scanned into the chart in a timely manner. Not a month later. Sometimes it doesn't get scanned into a month later and I have to go track it down. We really need these scanned in after the event, within a couple of hours.
Evie, quick question. It states on there that the code flow sheet has to be signed by the MD as well, but I don't see a signature spot for the MD on the flow sheet.
Is a team leader?
There's a team leader.
That's usually the MD. The code blue white flow sheet gets scanned in the chart, but this postcode evaluation form does not get scanned into the chart. Please do not scan this into the chart. This is for resuscitation committee, for quality improvement, to communicate things that would not be on the code sheet. When you complete this form, it gets emailed to the AKA code at anthc.org. But you can put the patient's medical record number and name on that so we know who it belongs to. I mean, I can track that with dates, but it is okay to put the sticker on that and email that. And then leave the postcode form for your unit manager to review. And of course, as I mentioned, the flow sheet gets scanned into the chart and should go down to medical records. Anything else on this? This information on this postcode evaluation form is very important to the resuscitation committee. So please make that part of code flow sheet and the evaluation form are both key documents for us to review. So we are reporting our codes on the reports portal under the quality, clinical quality area. Next slide, please. It actually, so under the, when you click on clinical quality, it goes to ANMC codes. There's a bunch of different headings you can click on. So ANMC codes, next slide. And on the ANMC codes, you'll find the number of codes and location. And there's a little caveat this right now. There's a little glitch. To get the location to show up, you have to click that menu button. They're working on fixing that so that when you just click down, do it automatically. But click that menu button, the page opens up better. You'll see the number of codes to the left and then the location down below. And the Get With The Guidelines measures are also on there. So if you, this is the presenting graph of the percent that met the criteria. Here's your quality measures. And if you hover over these, it will tell you what the result is. And if you click on this button here, next slide please, it takes you, oh no, where'd it go? Try the next slide. Oh, must have deleted that, sorry. Go back. There's a really nice, so I'll play around with this. There's a really nice graph that explains this in another, just another view. What I like it kind of better than this view, it's a little easier to understand. And then there's also, with the filter, you can change location, you can look at pediatrics or adult, and then you have to hit run report, and then it'll upload that data that you requested. Next slide. A couple caveats on the portal. If the appearance of missing data may just mean that the measure wasn't applicable. So if the presenting rhythm wasn't VF or pulseless VT, you're not going to see any data for that. But if it did meet the measure, you'll see a 0, and then you'll see what the percentage is. So there's a couple things that you use to when you're reviewing that data. A lot of information gets uploaded to the portal, so there might be a glitch or two. Just if it doesn't seem to work out, maybe go back to it later on. And as I mentioned, the filters and pre-hospital arrests do not get entered into Get With The Guidelines, but I do enter the total codes on campus. So you'll see ED codes. Those will include pre-hospital arrests, but if they don't meet Get With The Guidelines, meaning they came in with CPR in progress, then they do not get put in Get With The Guidelines. So you will not see that information on the Get With The Guidelines results. And to summarize, the documentation is really, really important for abstracting this data and tracking where we are with our resuscitation efforts. So we can provide educational opportunities such as this. We can focus our instructors on areas in ACLS that we need strengthening. And please provide as much detail as you can. Fill in all the blanks. Those questions are there for a reason. And complete the postcode evaluation form. The resuscitation effort requires teamwork. You guys are all working really hard. We really appreciate that. And we know how difficult codes are, especially when you don't see them that often. But take a deep breath. Think about it from time to time. How would your team, if you work with a group of nurses, how are they going to respond? It's not a bad idea if you're the charge nurse. You have a patient who's looking really not good. Hey, I'm kind of worried about this patient. Maybe set some, who's going to be the documenter, who might take some different roles. You know, where might you put the crash cart in the room? Just things to think about as you're, you know, working on the ward, just so you can be prepared. The more prepared you are, I think, the smoother things generally go. So we can then move to Brian and Julie can discuss more about end-tidal CO2 monitoring.
So, I think it was about 2 months ago maybe that, excuse me, I presented at a nursing grad rounds. I think it was in November if I'm not mistaken, but my name's Brian Faix. I'm the manager of the respiratory therapy department. This is near and dear to me. When we sit down every month and we start looking at the codes and go through the numbers, this seems to be an area that we struggle with, despite a lot of attention being paid to it. And the more and more that we dig into the process, you know, we can kind of identify that there's a couple of issues that I think are preventable that will help increase our compliance with using end-tidal CO2. The big thing to understand, though, is it's not just a number. You know, those of you that have gone through ACLS know that end-tidal CO2 monitoring and the number that's being presented to you is really instrumental in making decisions and also gauging how effective we're being in our resuscitative efforts. So there's three main things that end-tidal CO2, that number that pops up on the monitor regardless of which one we're using, and we'll go through this in a little bit. But there's three main things that helps you with. Number one is determining your quality of chest compressions. And I'll talk about each one of these individually. Number two is detecting return of spontaneous circulation, or ROSC, quickly. And then the third thing is termination of resuscitative efforts. So the first thing is quality of chest compressions. So your end-tidal CO2 directly is correlated to what your cardiac index is, which is a reflection on perfusion. So as we're pumping on the chest and doing CPR, we're doing the work of the heart. Normal cardiac index in a patient is typically between 2.5 and 4 liters a minute. And that's generating an end-tidal CO2 that's between 35 and 45. So that's a normal end-tidal CO2. During CPR, we typically see cardiac index, what we're aiming for is at least 1.6 to 1.9 liters a minute. And that's going to give you an end-tidal CO2 that's between 10 and 20, which according to ACLS is also indicative of high-quality CPR. So that's kind of what we're aiming for. So when we're looking at the numbers, regardless of which monitoring system we're using, you want to at least maintain an end-tidal CO2 that's between 10 and 20. That's what we're aiming for. The second thing is in determining ROSC. The number that's indicative of ROSC is about 25, and what will happen is you'll see, you know, if your end-tidal is kind of hanging out between the 10 and 20 range during CPR, and then abruptly see that number shoot up to 25 or 30, somebody should be thinking we need to check for a pulse because there's a high likelihood that we've gained ROSC with the patient. The next thing is an end-tidal CO2 that is less than 10, that's sustained for greater than 20 minutes, is also an indicator of it's very unlikely that you'll have a successful resuscitation. So after 20 minutes of a CO2 sustained below 10, we should be thinking about terminating resuscitative efforts. Does all that make sense? Do you guys have any questions about the numbers?
How long did you say the last one?
So an end-tidal less than 10 for greater than 20 minutes. So what you will see, we'll go through some of the equipment if nobody has any questions. And I will say this also, so the presentation that we did back in, I think it was November, I'm pretty sure, that was all uploaded to HealthStream. So if you're interested in capnography, which is the waveform piece as opposed to the number piece of this, there's a lot that the waveform that you'll see on the monitor will also tell you. I don't want to cover that right now in detail because it's a 45-minute long presentation in and of itself. But that's all on HealthStream if you're interested in reading about capnography in more detail. But
And the Zoll only gives a number versus a waveform.
Right. Yes, I think it depends on the Zoll. I think ours, yeah, it doesn't give a waveform capnography. It's just the Philips monitors, though, they will give you an actual waveform. So, anyways, so different kinds of devices that we have sitting on the table here. I can't stress it enough what Evie said about even a patient that's intubated, we still need to confirm placement of that tube. So if it's an intubated patient, they already have an airway established, we start doing CPR in a code situation, we still need to verify placement of the tube. The code could be a result of the tube being dislodged or displaced, or it's not in anymore. We need to make sure we have a patent airway. That's step one in the process. A couple different ways of doing that. There are colorimetric end-tidal CO2 detectors, and then there's quantitative end-tidal CO2 detectors. So this is the color one, as everybody sees. So this comes in a package. This pops on the end of the endotracheal tube. You attach the bag to that as you're ventilating. And it's colorimetric because it changes colors. So when it comes out of the package, they're either going to be blue or purple when it's not in the presence of carbon dioxide. As you start ventilating and you have your airway placement is good, you'll see it turn from purple or blue to yellow. So yellow, yes, is a good way to remember that. And when you see yellow, again, I think it's also communication is a big piece of this. Whoever's looking at that needs to call out that the endotracheal tube placement has been confirmed so that whoever's documenting can document that in the appropriate spot. So that's color end-tidal CO2 detection, and then really the gold standard is using quantitative end-tidal CO2 measuring. So all that means is it's just giving you a number instead of changing colors. So two different ways to do that. We have the Philips monitors that you'll see in the intensive care units, and then the Zoll, which will be on every code cart. I want everyone to be comfortable with knowing how to set both of these up. So this will be an interactive exercise, so people can come up here and you can play with it and learn what this is. But we think of this as a responsibility of the respiratory therapist that's responding to the codes. But the reality is if the RT is at the head of the bed and they're ventilating the patient, it's going to be very hard for them to break from that to set this up. So I think it's important that, again, we partner with nursing to make sure someone is doing this because it's an important number. The data that's being given to us is important. And again, it's about quality improvement and ultimately patient outcomes. The first thing I think I'll start with is a Zoll monitor, so I'll just flip this on and let it warm up for a second. Get it to the right spot. So in the code carts, on the top drawer, are where the capnostats are kept. So there's a pediatric one, which is purple. It's a good way to remember it, or infant. And then the adult/pediatric one is white, and clear. A couple of important things with these. So when this comes out of the package, I'll pop this out here so you can see it. So this is what it looks like. Like Julie said, it's best to keep this as close to the head of the bed or the side of the bed as possible, because we have gotten feedback as we've reviewed codes that the reason that people aren't using these is they tried to use them, but then the cable won't actually attach to where the endotracheal tube is based on where the monitor is being positioned. So there's different ways of putting this in line, and I will say you have to put this in the right way, even though it'll fit two different ways. It won't give you numbers and it won't work if it's not lined up the right way. I can pass one of these around, but the thing I want people to take note of is on the end of this capnostat, there's an arrow that's on it. It's a clear arrow, it's kind of hard to see, but it needs to align with the dark arrow that's on the end of the cable for monitoring. So you have to match the two of those up. Once that's put in place, it'll take, I think we tested it was about 30 seconds for this to warm up. And you'll see on the monitor here in just a second. So what we're going to do is, when you hit manual mode, hopefully everybody can see this, if not,
Do you want it
around here.
the monitor turned?
Okay.
Okay, so manual mode, confirm. And then parameters. Does everybody see this button on the bottom here? So it's sifting through things. That's how they get to the end tidal spot. And then you'll see CO2 right here in the middle. Click on CO2, and then the last step in the process is enable CO2. Hit that, and then it's going to start saying warming up when this is in place. Betty and I played with it, I don't know, for a little while. I think we got our times about right, but it takes about 30 seconds for this to warm up.
And according to Zoll, it can take up to 2 minutes
Yep.
and not be broken.
Can the cable be plugged in and have it warmed up before you're actually attached with the?
Cable's always plugged
Yeah,
in.
so the cable will always be plugged in, but if we know that we're in a code situation, when we're setting everything up on here, getting this going is also a good thing, because it's going to take a couple minutes again for it to warm up
Yeah.
and be ready.
So that has to be attached.
Yeah, so
like
you have
at
to put,
before you can hit warm up.
correct.
So,
And it's also, so there's going to be another step in the process too that I'll show you. So before it goes on the patient, it has to warm up, and like I said, it takes a little while to warm up. And then there's also a zeroing process to make sure that the data that we're getting from it is accurate. So we'll give it a couple seconds here to warm up, like I said. But does anyone have any questions about the setup on here and how you get to the CO2 menu on the screen?
You want to just say them again? What was it?
Yeah.
Sure, so manual mode,
Manual.
confirm. Parameters. CO2. Enable CO2. Hard to think through it. Okay. So now this is warmed up. So now you see on the screen here, the yellow box in the bottom is active. So the next step in the process is hitting the 0 button. Okay, so now it says zeroing adapter. I think this took around 15 seconds maybe. So you can see this takes a little bit to get this going. Okay, so 0 done. So this is now ready to put in line. Again, we want to make sure that someone is keeping their eye on this process. It may not be the RT, they may not be in a position to be able to help to do this. I think it's important that someone that's involved in the process is making sure that this is being accomplished and done. Go ahead.
To know that the arrow is the right way, the wire goes up instead of down.
Okay. And, yep, and it's also, you know, again, I don't know if anyone wants to come up here and look at that more closely to see where the actual arrows are. But you can see how the clear arrow on the Q that lines up with the dark arrow on the K.
Okay, so it just.
Because it will fit. If you take it out and you flip it the other way, the arrows won't line up and it will snap into place.
See how tiny that is? Oh, jeez. I don't mean to be, you look way better with it. Oh, right there.
oh,
It just snaps in and out?
Yep, you can, and you can pop it out if you want.
Okay. Okay.
Like I said, that's one of those things that's easy to put it in backwards. You really have to be cognizant to make sure the arrows are being lined up.
Oh, and it works?
Yeah, and that's the danger of it, is that it will go in both ways. All right. Any other questions about the Zoll, or is there anything else that you guys think that I didn't cover that I need to? All right, so I'll shut this down. All right, Philips monitor is next. So like I said, you'll see these in the intensive care units. And it's a different process. So this is how they come out of the package. The important thing is, as you know, this is an add-on piece here. So not all of the monitors have those. So you have to actually make sure that you have one that has end-tidal monitoring capability. So if you went into the intensive care unit upstairs right now, not all of the monitors have those. So a lot of times I think you'll find it easier to use the Zoll because everything that you need is right with the device and it's inside of the code card. With this, it does take some hunting to try to find one of these modules.
Why don't we have enough for every single one? Just-
It would be nice if we had some more. It would definitely make it easier. It's expensive, of course. Right?
Well, I'm sure there's not, I just didn't know.
But I guess the point is to, you know, if it's a matter of, if it's going to take 10 minutes for someone to try to find one of these, I would just stick with the Zoll.
Is there a time frame which you have to have done this, like, confirmation by, or do they just want to do it sometime?
As soon as possible, I would say. There's not a time. It needs to be called out within at least a 5-minute interval, the actual numbers. But the point at which we start resuscitation, it should be just like we're thinking about meds, just like we're thinking about pulse checks, rhythm checks, all that stuff. We should also be thinking about end-tidal CO2. Okay. So I'll try to show everybody this. The way that this plugs in. So the end, this is similar to what we were just looking at on the Zoll, except this filter line. What happens is the end of this, it's like a corkscrew. There's a little door. Sorry, I just broke this.
Here, can I be your assistant?
Yes. I was gonna like hold it and try to twist it up. Okay, so there's a door on this on the side. So that door just comes down and then this twists in place. Okay, so now that's in line and then you put this in line with the endotracheal tube and again your numbers will start. And hopefully I didn't break it to the point that it doesn't show up. It's one of the things that it will pop up on there and then we're good to start recording numbers. Yep. So this is for invasive monitoring. So endotracheal tubes, this goes in line with those. And then we have another one here that Julie dropped too. That is for non-invasive monitoring. Have you guys seen the nasal cannula ones?
Super useful.
And this is the same concept. So nasal cannula. This is a sampling reservoir here. Everybody always wonders what this is. But that's a little shield that's actually catching exhaled CO2 also out of the mouth as they exhale.
Does
So
it catch it
that's
out of the
It's like a
nose as
scoop.
well?
Mm-hmm. Yeah. it does
So
both.
it catches both,
Yeah, I don't know
okay.
if you guys can see in the back side of this, it looks like it's all sealed, just like a bubble. But on the back side, when you flip it up, it's called a scoop. So it's picking up end-tidal CO2 that's being exhaled through the back part there, and then going through the monitoring.
And then,
Yep. And then this piece, so that's the monitoring line that's coming off right here. And then this is for connection to actually attach it to an oxygen line to provide oxygen therapy. These, I'm pretty sure, are unilateral, which means that one side of the nose or one nostril is for monitoring CO2, and the other side of the nostril is what's actually administering oxygen. They do make some that are, they do both out of both nostril, but I think ours are unilateral, where it's one for monitoring and one for administration of oxygen.
You actually can use oxygen or not use oxygen with it.
Correct. Yep. So the way that it is right now is perfectly fine. You could put this in line with someone and it'll monitor if they don't need oxygen therapy or support that way.
Why don't you show us on Julie how it works?
Right?
the dummy.
Well, this one's been used before, so I probably wouldn't put this on anyone, but I think it's just for testing purposes. I should clarify. It hasn't been. We're not that cheap. But anyways, yeah. So these are good also for monitoring. You know, if you have, you know, in some cases, I know that everyone doesn't have access to these, but for monitoring patients that have sedation going or epidurals, things like that, end-tidal CO2 monitoring. That's one of the purposes of doing it. Any questions? We kind of covered all the
So
big
is that how
things.
it's supposed to look on the screen? Like, because I don't use those. So.
No, so.
Oh, there, that's more. You
Yeah.
can come up and, so you'll actually get a waveform and a number.
Okay.
But we're not showing it because
Yeah,
we're not
I
live.
just, okay.
But yeah, that'll show up. Does anyone have any questions about end-tidal monitor?
Who wants to come up and,
Yeah, if you haven't had a chance to play with this,
yeah,
it's a good opportunity to do it.
Sure.
And like I said, if you're really interested in it, check out the video that's on there.
It's just,
so you pull that down. And twist. No, that's it.
okay, I was like, I've got pretty good arm
Yeah.
strength.
When it comes to calling out numbers, so this is another thing I'll just touch on real quickly. You know, we've been encouraging our staff to participate in that process and try to be the leaders in that. But I will say, depending on where you're at, if you're in an intensive care unit, so up in CCU, for example, if the RT's at the head of the bed and they're manually ventilating, the monitor's behind their shoulder to the left. So they're not going to be able to see the numbers. So that, again, that partnership, if you're recording and you don't have anything in that end-tidal CO2 box, either look at the monitor and see what it is and write it down, or ask somebody to look at the monitor and see what it is. Because depending on where the Zola is positioned, or depending on where the monitor is in the room, the recorder and the RT may not be in a position to see that. So it's going to rely on, you know, the rest of the team to be cognizant of those numbers and call them out.
Anyone have any questions about, with the guidelines? Documentation, documentation, documentation. Don't be afraid to call out, did we confirm the airway?
Do you guys do drills? I'm not sure if I've heard a code blue drill or not.
Yes, we have done some in past years, not for a bit though.
I find them helpful.
We did one
I
recently,
agree.
it was in the last month or month and a half, we did one in L&D. And it was a
Okay.
joint
I did
L&D
hear that,
code
yeah.
light type situation.
Yeah.
I think that was the last one that we did. So we did get a response, so we had an adult team that was there, and then we also had the NICU team for babies. So
Okay.
I thought that that was good. It was a good process.
So I have a question for the signature chart. So if you are recording and all of a sudden the code blue ends, everyone's like out of the room, you're still recording and just kind of finalizing things up, you just have to follow whoever is there to have their signature signed?
Hunt them down.
Yeah.
Well, try to get them before they leave the room. I mean, usually, recording ends usually when the event ends. Obviously, if they take the patient to the unit, the doctor's probably gonna follow the patient, but try to grab the doctor and have them sign it, or, yeah, later on, contact them and try to obtain those signatures.
I know that used to be an issue on L&D when we got code whites, we were often chasing the provider down, but it was always kind of specified that that signature really is signature to confirm all orders, right? Medication orders and stuff that are on that, so, you know, that's another reason to ensure that that signature is on there, is that you're not acting without orders.
That's a great point, Shelley. Yep, that piece of paper needs to be signed.
Do they sign, if there's multiple pages of this, do they sign one of the pages or?
No, they just need to sign the first page.
What about the fact that we assign a team leader at the beginning of the shift, so, and then,
Well, it's a code team leader. It's
right,
whoever
that's assigned at the beginning of the shift, the nurse is assigned. And then as soon as, so the nurse will be written down halfway through or whatever until the doctor shows up and then they become the team leader. So there kind of should be two spots, like a doctor's
Not only the
signature.
doctor, I mean, yeah, have them sign both. I mean, that really hasn't come up.
Okay.
And there's really only so much room. We've done our best to include a lot of information, but if there's a nurse team leader, have the nurse sign and the doctor. And you can write below there. It's not a big deal to write outside that.
I also think the more, and she talked about feedback, but I think that the more feedback that's specific, whether it's things that were positives or things that could be improved on, it's hard for us when we sit down in a room and we kind of go through this after the fact, you know, and we try to figure out areas for improvement or what went well, because we do pass along positive feedback too. The more information that's there, the easier it is for us. It's hard to go back through and try to piece the whole story together. And it's really nice when you read the sheets, there's a lot of good feedback for us to come up with recommendations and, you know, what we did well, what we can improve on. So.
And the nursing narratives are great. We really, really appreciate, you know, nurses taking the time to write a paragraph on what led up to the code. Any other questions?
Is there a way that, I'm sure there are several people from my floor that would love to get together and just run?
That's
Never
exactly
had
what
to
I'm writing
run
down right now. Like, I'd love to
code
practice
before.
it with our team.
Like, I had to ask, I'm like, where do you get that cord? I check, I'm a charge nurse and I check that, but a lot of that stuff isn't out and I don't know what's in every drawer. I don't get to just open a drawer and look and see what's in it.
And even if you do, I don't really know.
So how do I know what's
Until you're
in
using
there?
it.
I don't have to be LCS,
ACLS.
ACLS on our floor, so I want to be able to help whoever I need to help, but if I don't know all that, then how can I be a good resource for somebody else?
Right. That's a great point. Julie,
I'm listening.
are they, you know, we used to do at the annual skills fair, they always did, you could play in the crash cart, there was a code review. Now that's changed, it's more unit
So in
specific.
2019, there was no annual skills fair, and there was no mock code program going on.
Is there anywhere where they could go to practice a code or to play in a cart?
ACLS and PELS class.
Well, and
That's-
Sterile Supply, I believe,
You're
has
right.
one practice cart down there that units could sign.
They do?
Well, is
I
there-
believe,
is- yeah.
Yeah.
They have one.
It took forever to like get it, but like I took a crash cart around on all the units on night shift. But there's going to be more like common moving on into the next year, so people can like play around and know where things are and get that didactic.
Oh, that's
So-
great, Gary.
Yeah.
So is there a
We
way we
use
could
it for
sign up as a
simulation.
group to do a simulation? Like, let's say I got from 4 West, if I could get a group of however many people you need, could we, I mean, we've got technically 4 extra hours that before we go overtime. Is there a way that we could get, like, so that we could run a code together? We're the people that are gonna always be together on that shift.
So really to me,
No?
I'll talk after recording.
Okay, perfect.
You know, but you can also talk to Sadie, or, you know, definitely bring those requests up.
I know in OB, we do OB simulations, and we sign the crash card out from Sterile Supply, and so within our department, we are simulating them. That is something that our department has, or that department has kind of taken on their own and done. So it seems like, you know, if you can work with your managers or directors to get some time for that, it would be feasible.
Well, that's definitely a goal that we can strive for, is to get people more familiar with the cards, more comfortable with the equipment. So that's why we're, you know, making these presentations, having these talks. So all your feedback's great. Let your managers know what kind of education opportunities you're interested in. And we can make that a goal. All right, well, thank you.
Thank you.